So good morning all again, and I'll be speaking about transpupillary thermotherapy for CSR. So as Sir said that PDT still remains the treatment of choice, but there will be, in our developing country, we will have a lot of patients who will be not affordable for PDT. So we should have a treatment option for those same patients. So TTT was first performed for choroidal melanomas and other malignant tumors, including hemangiomas and even subfoveal CNVM. And CSR has been traditionally treated with laser photocoagulation, but with the recent treatment updates, we have TTT, PDT for the subfoveal leaks, which cannot be traditionally treated, by photocoagulation. So the mechanism actions of TTT is based on thermotherapy, that is induction of a modest thermal elevation of RP and choroid, which is usually between 4 to 10 degrees Celsius above the basal temperature. And this is compared to the photocoagulation is almost 1/4 to 1/6 of hypothermia, which is caused in TTT. And the mechanism is basically what happens is RP debridement with migration and transformation and reproliferation of the RP cells, which forms a scar, and probably leakage will stop from that place. So again, a deep, low, prolonged hypothermia leads to hyperrepression of the heat shock proteins, as well as vascular thrombosis and apoptosis of the endothelial cells, which further lead to blood flow stasis and decreased leakage in the CSR patients. It's a small video which can show you a mechanism action in a pretty little better way. So that is the thermal interaction in the retina and the RPE, and the laser once given affects mainly the choroid and the RP layers, and with further coagulation, and surrounding areas also get coagulated, and further we have RP cells which starts regenerating and occupying the space which was basically because of coagulation had been damaged. So the advantages of diode laser, that is 810 diode laser, we have it has a deeper chorioretinal penetration. There is no change of the tissue architecture with this, and because of the low absorption of the by xanthophyll, it minimizes the damage to the nerve fiber layer. Again, poor absorption by the hemoglobin, so it allows treatment through the subretinal and the preretinal heme in cases of CNVM. So in CSR, we have subretinal fluid which protects the retina from the thermal damage which might have been caused. And again, with subretinal pigmented lesion and blood which are actually absent in CSR, so it doesn't accentuate any neural retinal damage. So to remember this, we in TTT we are using the TRUP threshold power instead of threshold power, which is ideally used in CNVM patients. So using a TRUP threshold power, we can avoid gross damage to the macula. And since chronic CSR is a diffuse choroidal disease, subthreshold TTT can be definitely a very good potential treatment for chronic CSR patients. Again, the same thing, the tailoring the therapy, maximal treatment effect and minimal toxicity would be our perspectives. So just a small unpublished data and our experience in our hospital of TTT laser. Again, inclusion criteria remain the same as Roddy sir had discussed for the PDT. It is persistent serious detachment more than 6 months, RP window defects, single, multiple subfoveal leaks, diffuse leaks of undetermined sources, neurosensory detachment of the macula on OCT, and treatment was performed only after obtaining informed consent. First, we usually give a patient a choice of PDT because that remains the mainstay of the treatment, but some patient which may not afford the PDT laser, we advise the TTT laser for those patients. So exclusion criteria, any other macular diseases or vascular, non-vascular retinopathy. Methods again remains the same. It's patient assessed at baseline, follow-up examination every 3 months, and then 3 months thereafter. So TTT is done with an 810 nanometer long pulse diode laser, and the mainstay standard contact lens is used. We use a recent fundus fluorescent angiography which is done, and spot size is selected as per the active angiographic lead, which is measured just like a GLD, that is greatest linear dimension in PDT. But the point to remember is in this spot size is basically seen, the GLD is seen in the middle phase of the FFA and might vary from 1.2 to 3 millimeter. So this laser is a very kind of a portable machine, and it can be very much slit lamp mounted. It can be mounted on the slit lamp. You can see the adapter which is mounted in the slit lamp here. So that's the adapter, and that's the portable machine. So how to do it is basically we have to choose a slit which should be very minimal in size and width, and so that we can very well appreciate the laser burn, that laser spot. And because if we increase the width of the slit, the blurring of the laser spot will cause we won't be able to appreciate. So it is basically done in the dark, and we have to point, maybe with the slit we can just focus a small indent of a vessel or kind of a vessel bending or a crossing, so that it doesn't, even if the patient moves, we are not moving away from the treatment spot. So subthreshold power means we are reducing the power by 60% of the threshold power. So threshold power, which is usually we see it first in the infranasal quadrant, and whenever we have a light graying or light blanching, or even if patient complains, we can see minimal blanching would be the threshold power. So that is a very important step, because we might get a little more threshold power and we'll reduce it by 60%, may not be a good committed reduction. So the duration of treatment is 60 seconds, that's a long pulse, and if retreatment is needed, we increase with 20% increase in the power from the baseline, and if significant reduction of the macular fluid was absent. So this is what we call it as a graded fashion. So that's the machine which we use, that's a power 240 and long pulse with a 60 seconds duration. So we have a few around 22 patients in this group, and whose mean age was 46.5 and mean duration of 16 months of CSR. That's a pretty long chronic CSR patients. So the baseline OCD features for almost every patient had SRF, followed by 86% had PED, and cystoid spaces with exudative RD almost in 9% of patients, with fibrin in 9% of patients. This suggests we have a pretty chronic patients in which we have tried this treatment protocol. Again, baseline FFA features, we can see most of the patients had 45% had diffuse ooze, suggesting it to be a chronic CSR patients. And again, followed by a subfoveal ink blot leak in 32% patients and subfoveal leaking PEDs in 18% patients. So the pre-treatment and the post-treatment mean best corrected visual acuity had been statistically significant in the post-treatment. It's gone to 0.58 logmar to 0.35 logmar. The mean CMT had reduced to 238 microns post-treatment. That again has been statistically significant in post-treatment TTT of CSR patients. These are the OCD features post-treatment, and we can see that only 23% of patients had SRF persisting, and followed by 82% had a PED there persisting. However, cystoid spaces and RP degeneration, foveal thinning were probably the responsible features of like in the patients who had not gained the visual acuity. These were the features because of which they had not gained the visual acuity. So just a short comparison we did in these the cases what Ronnie sir had presented in low fluence PDT. So again, it remains, as I said earlier, it remains the mainstay. That is, mean duration of resolutions were almost 5.41 weeks in low fluence PDT. However, in TDT it was 7.12 weeks. Again, mean number of sittings was again statistically significant, and low fluence PDT almost required just a single sitting. However, in TDT we might require around 1.41 mean sittings. In final outcome for our TDT patients, we had almost 77% resolved and 23% remained persistent. So this is just a prototype case which we had done a pre-TDT. That's we can see a fibrin there with the fibrin with the SRA pocket, and in OCD we can correlate the same features, like this is the fibrin and the SRF pocket with the PEDs there. Post-treatment we had again the SRF has disappeared and PED remains, and even the subretinal fibrin had disappeared. So to conclude, as low fluence PDT serves as an excellent treatment modality for chronic CSRs. However, the cost burden to the patient is important in our countries like India and other developing countries. So graded subthreshold TTD is an effective treatment option in such situations where patient cannot really afford the low fluence PDT, and so but we have to explain the patient that they might require marginally higher treatment settings. And power setting what we use is very safety enhanced, and which will cause avoid any damage what usually happens with TTT, like macular burn and RPA atrophy, and so we don't have any complications in our series till now. This is a published data already we have published in OSLI, that is graded subthreshold transpupillary thermotherapy for chronic central serous retinopathy in Ophthalmic Surgery Lasers Imaging Journal in 2012. So we compared our published data with the published data earlier, that was Nasmulisan et al., which was published in 2006, and D. Shukla et al. In 2008. So they had 14 eyes in Nasmulisan series, and D. Shukla had 25 eyes. In our study, we had around 10 eyes. The duration we choose, the mean duration of symptoms in our series was almost 20.3 months. That is way far above the D. Shukla et al. That was just 5.4 months. And even in Nasmulisan, they just had a mean of 4 months approximately in their series. So our series had the most chronic patients probably. And again, power used for Nasmulisan et al. They chose everything arbitrary. There was no fixed protocol for the same, the power, the spot size, the duration. And whereas in D. Shukla et al., they used power 260 to 120, spot size of uniform 0.5 millimeter with duration of 60 seconds. However, they reduced the threshold power only by 10%. So that's as per our knowledge, I think it's very risky for the macula. And however, we used approximately reduction almost like 60% of the threshold power. So that was we were pretty in the safe zone for treating those macular leaks. Anatomical results, they had around Nasmulisan had almost 78% resolution at 3 months, and we in D. Shukla had around almost 96% resolution, and we had a good success rate of 80% resolution in 3 months. Function results were near or less same. 50% of patients had more than 3 lines in Nasmulisan et al. Series, with 88% of patients had 20/30 more vision in D. Shukla et al. And we had around 50% of patients which had more than 3 lines improvement, and 30% who had 2 lines improvement. So overall it was around 80% visual acuity gain in our patient. Complications, we had no complications using a THREP threshold decrease in the power of 60%, and however D. Shukla et al. Had almost one case of CMEM which was further treated with TTD itself. However, they used threshold power later on. But we had no complications using this 60% reduction in the power, and plus the retreatment. Yes, we needed retreatments. In 3 years, we needed 2 sittings, and 1 eye we need 3 sittings in a mean follow-up of 7.4 months. Thank you.